I was in a general surgery residency program where it was called a pyramid program or a cut program, where you start with a larger number of interns. And as the years go by, they weed them out. And the main cut is at the end of the second year, where 50% to 75% of the residents are told, you're not staying for the full thing, go find a job elsewhere. And it's a harsh reality, if you will. And so you want to do everything right in those first 2 years. You don't want to have any black marks, anything you can be criticized for. It becomes a real toe the line type of situation. But of course, you're in a surgery program. You want to operate as much as you can. The way that it works is that the intern who's on call for that night gets all of the new patients who come in that are going to have surgery the next day, and they have to do their history and physical exam on them the night before. Get everything ready for them for surgery. And the cases usually are sent from the surgical clinic, where all of us attend the clinic, and as we see the patients and decide that they have a surgical problem and need surgery, they get scheduled for surgery by the level of the resident according to your expertise and training level. So for instance, a gallbladder case is a second-year case, an appendix a first-year case, calling it the appendix the gallbladder, but a person with a bad gallbladder, a person who has an appendicitis, etc. And so what ends up happening is, and usually the appendix is an emergency case, but the point is it's a first-year case generally, as are hernias. And the night before, it turns out they had a case for me. I was supposed to take out this lady's gallbladder. And she'd been sent from clinic where somebody else worked her up. And now I'm doing the history and physical. And the more I talked to her and was spending time with her, and the senior residents used to criticize me because I spent too much time with the patients. You were only supposed to spend at most 25 minutes and be all done, dictated, orders written, and everything, 30 minutes, start to finish. And the history, though, was most important. We learned this early in medical school. And so I'm taking the history from her, and she has this pain that got worse with meals but didn't go away. Usually gallbladder pain, you eat, gallbladder squeezes. If you got stones in or a problem, you'll get pain from that. But after the meal passes and things go on, eventually that pain goes away. But her pain persisted, and it became worse and worse as days had gone on. And that's typical more of an ulcer. And of course, then when you eat, the pain gets worse because acid gets elaborated and discharged into the stomach. And I just told her, I said, I don't think you've got a gallbladder problem. Even though they'd seen a gallstone on your x-ray, I think you got an ulcer, and they didn't work you up for that. You need certain x-ray tests, and we can't treat you and take you to surgery, take your gallbladder out unnecessarily. When you have an ulcer, put you at risk. And she said, okay, that's fine. I said, I'm going to cancel your surgery. Well, the next morning on rounds, you have to present all the cases. And so I had the whole team, and I presented the case, and I said, yeah, this is someone. She's my patient that I'm supposed to do gallbladder surgery on today. And I said, I want to cancel her case because I don't think she has a gallbladder. And the senior resident was really upset. And he said, what are you talking about? Harch, you're in a surgery program. To cut is to cure. You need to cut to cure. If you don't want to do surgery, you're not going to make it in this program. I said, well, the problem is I don't think she's got a gallbladder problem. I think she's got an ulcer. And they said, well, how'd you come about this? And I went through the whole history. And this had been higher level residents that worked her up, and I'm the intern, and I'm now challenging their diagnosis. I just said it doesn't fit. And what do we have to lose? If it turns out I'm wrong and it's her gallbladder, we do it another day. Let's get the studies. And so in a very exasperated fashion, the senior resident said, fine, cancel the case. It doesn't look good to you. I said, that's okay. I don't want to do something that is going to be a problem and potentially cause some real harm here. So we finished, we got out of that room, we went down the hall, we went through all the other patients, and we were down the hall about 5 or 6 rooms, and we hear this blood-curdling scream from the nurses. Doctors, come out here immediately. And we all ran down there, and here was my patient with the gallbladder problem, sitting on the side of the bed, and a 3-foot diameter puddle of bright red blood on the floor. She had just vomited all of this blood. Turns out when we got her resuscitated, got fluid in her and everything else, and did the study. She had a giant gastric ulcer, 3 inches long in her stomach, that had eroded and into a blood vessel and caused bleeding. If we'd taken her to surgery, we would have killed her. She likely would have died intraoperatively. So to cut was to cure. In this case, to cut would have killed her. The surgery got delayed. A good outcome. It was an issue of kind of not following orders obediently and trying to do what I thought was right. It worked out.